So today we are going to discuss clinical ultrasound of the thyroid. We are going to discuss the role of ultrasound in terms of evaluating the thyroid, the anatomical reminders, how to locate the thyroid, how to find landmarks that will help you also to locate the thyroid, normal ultrasound findings, and pathologies. We will also dive into ultrasound of the salivary glands and the lymph nodes. General practitioners come across thyroid pathologies quite frequently. So it is very important that the ultrasound tech knows how to properly evaluate the thyroid. Some of the things that would warrant having a thyroid ultrasound would be suspecting pathologies or cancer. So we can have visual enlargement, we can palpate enlargement. Ultrasound is very popular as an exam that is done initially to diagnose because of the low costs. Also, it is very minimally invasive. When do we perform an ultrasound of the thyroid? So neck pain would, of course, any type of pain in the body would warrant further evaluation. So neck pain, the presence of thyroid nodules, a thyroid goiter, metabolic imbalances, which are hormonal imbalances such as hypo or hyperthyroid. Post-thyroidectomy follow-ups. So if patients have had thyroid cancer, that would be a great reason to have a thyroid ultrasound done, usually within a few months post-ultrasound, just to check in to see that things are healing properly and that the surrounding area does not contain any inflammation and things like that. Exploring the thyroid is pretty straightforward. It is a very superficial gland. It is located right underneath the skin. It's anterior. In the anterior face of the neck. It's palpable. It usually weighs about 10 to 20 grams. It is consisted of a right, a left lobe, and an isthmus, which connects both lobes. There are some instances where we can have a pyramidal lobe. It's not quite often seen, but I'll show you an image. These images here are showing the thyroid in a few different views. So we have the posterior view, which also shows us the parathyroid glands. Some sonographers or doctors, don't pay much attention. However, I feel like it's very, very important in diagnosing, and it gives clues in the patient's well-being. This is the anterior view, so it is showing the right lobe, the left lobe, and it is connected here by the isthmus. Here we have the superior view. I'm going to go to the next slide and show you how we normally kind of categorize the different anatomical locations when it comes to describing locations of where a nodule might be, or an area that we are focusing on, and how to communicate that properly. Communication is very, very, very important in any spectrum, in any field of healthcare. When it comes to the thyroid, it's very important to be very specific where nodules are located, how they're growing, and things like that. So we will get more into that. So you can see here the thyroid is divided into thirds. We have right and left, upper, middle, and lower thirds. This next slide here, we will see the pyramidal lobe. I have seen this lobe, but very, very rarely. I feel like it's important to know that it exists and that it is there because let's say you see that in your ultrasounds, you would want to know that that is a normal anatomy as opposed to a pathology or some type of inflammation. This slide is showing us the topographic anatomy. So in this slide, we can see that the thyroid is located between the C5 and the C7 vertebrae. The trachea lies right in between the thyroid and the esophagus. The esophagus is difficult to visualize on the ultrasound due to the air obstruction. In fact, the trachea is a tube-like organ formed by cartilaginous rings and filled with air, which might hinder the view of any structure posterior. This is the view of the trachea here, laying right in between the thyroid and the esophagus. This is depicting the vascularization around the thyroid and associated with the thyroid in this image. In terms of arterial vascularization, the lobes comprise of two main arteries, superior and inferior to the thyroid. We have in almost any thyroid view, we can view the carotid and the jugular arteries. They're paired on each side. Understanding the anatomical relationships of the muscles in comparison to the thyroid is very important because the echotexture will give us clues in determining normal versus abnormal tissue, and in order to correctly look for and determine pathologies. So if the thyroid is hyper or hypoechoic compared to different structures close by, such as muscle, it would give us clues into knowing if that tissue was more normal or abnormal, just giving the echogenicity. This is here the sternocleidomastoid muscle. The sternohyoid muscle also is close by. They are shown in the image laying right here. The thyroid is right underneath. There are also lymph chains that are located close by. They are shown here in green. It is very important to observe and to look at the lymph nodes because they are a great indicator in inflammation and certain pathologies. Moving a little quick, guys, because we only have an hour. All right, so here we can see the relationships between the jugular vein, the carotid artery, which is here. The jugular is also showing to be sitting next to the lymphatic chain, and also the lymphatic chain runs close to the carotid artery as well. So they are all sitting very close to each other, and they do play a role in determining pathologies, as there will be changes with each structure depending on the type of pathology. Things, for example, vessels can be compressed and lymph nodes can be enlarged or show other signs of abnormality, which we will get into later on. So the exploration technique is basically how do we locate the thyroid, how do we position the patient, and we will get right into that. So positioning is very important because number one, we want to make sure that the patient is in a comfortable position, also in a position which will lead us to being able to provide the best images and the clearest images for the doctor. So patient is going to lay supine. Keep in mind if patient is in a lot of pain or has, some type of, ailment that is just not, enabling them to pick their head up, you just try to lay them in the most comfortable position that they can, as far back as they can put their head. I've scanned patients that could not put their head all the way back, and just angling certain ways, the images will come out a little bit clearer. Adjustments can be made for elderly patients in terms of positioning as well. But comfort, I would say, is definitely number one. Please keep in mind that the patients are, some of them have diseases, pathologies that they're dealing with of the thyroid, and it can also sometimes put them in a bad mood. So always try to be very, very nice and make your patient very comfortable. In terms of probes, we do use a high frequency probe, usually 7.5 megahertz and more. We do utilize other probes in very special instances in terms of like a very, very enlarged thyroid. Sometimes a doctor would like to see that entire thyroid. So we can manipulate the image by changing the probes or using other techniques that would enable us to visualize the thyroid optimally. Regarding imaging modes, we basically use the B mode, which is also known as the real-time mode, and color Doppler. Color Doppler is very, very important in thyroid and any organ. I believe that you would scan to look for abnormalities because in terms of inflammation, you would see that there would be hypervascularity or sometimes hypovascularity. And these give us clues in determining different factors while we're exploring the thyroid and looking for abnormalities. In terms of sections, we usually scan in longitudinal and transverse sections. In general, there is infinite sections that can be made. So I encourage you to scan up and down, left and right, anterior, posterior, and as many cross sections as you can to make sure that you are thoroughly exploring the thyroid. So you would hold your probe in multiple directions, longitudinal and transverse, and just scan straight across, straight up and down. Okay. This is an image, of course, of a very large thyroid gland. There are many types of enlargements. One of the most popular would be a goiter. Okay. All right, so this is showing a beautiful normal ultrasound appearance of a longitudinal section of the thyroid lobe. In this section, we can see well-defined boundaries. We can see that the echo texture is homogeneous. We can see that there's no areas that are like more brighter or let's say more hyperechoic or hypoechoic than another area of the thyroid. It's nice and even, and you can see that the muscle layer is more hypoechoic. So we're looking at an ovoid shape, elongated, vertical with fine echo structure, homogeneous, and beautiful regular contours. This is the cross section. In the cross section, this is the transverse section of the thyroid lobe. We can see that it is more of a triangular shape. Also, it can look more trapezoidal as well. Specifically, now we're looking at the left lobe here, with the trachea, the carotid, and the jugular vessels are clearly visible. This is the carotid, the trachea, the jugular vein. By utilizing the color, we can definitely easily see the vasculature surrounding the thyroid. So this is the carotid artery. It is the smaller, rounder artery, usually seen right in the area of the thyroid that you're scanning. And this is the jugular vein, which is larger and usually more ovoid in shape. This is another image showing thyroid, carotid, jugular vein. This is an overview just of a cross-section of a normal-looking thyroid. We have the right and left lobes, and we have the isthmus connecting both lobes. Usually, the volume is calculated length with height times 0.523, and we will go into that more. We can see also in this image in terms of depicting that the thyroid ectotexture is normal compared to the surrounding musculature. We can see that it is more hypoechoic, the parathyroid muscles, and more hyperechoic thyroid. The thyroid does go through changes. For example, in Graves' disease, it would be more hypoechoic. In terms of calculating the volume, we would multiply length times width times height times 0.523 for the cubic centimeters. There are, this varies, I must say, from office to office and also from country to country. I've seen different calculations. This is the norm that I've usually used, but there are offices that do things a little bit different, so I would go by the protocol in your office. The size is expressed in volumes, and there are limitations in terms of adults, kids, and if patients have an underlying condition, we would consider that also. Anatomical variations. So there are many anatomical variations. I've noted that taller patients have a more slender thyroid, shorter patients have a little bit of a shorter and longer thyroid. So it does vary, especially in terms of the patient's age. We're going to go into the shape. So this here is more of a slender appearing thyroid. This would be a trapezoidal looking thyroid in the transverse plane. We are going into the variations of size. Size variations are very common. Sometimes one lobe is a little bit bigger or smaller than the other, and this is normal. The left lobe is often smaller than the right lobe. In some cases, one lobe may even exhibit hypoplasia or complete agenesis. Variations in size. Here we can see we're using a convex probe to evaluate this thyroid here. We're using a low frequency probe, and because the thyroid gland is a little bit larger in general in terms of size, the volume is 10 cc's. We are going into, in this image, we also had to manipulate the image by using a different probe. This was a panoramic system, which is a little bit more detailed and specific to certain offices. Hypoplasia of the left lobe, as you can see here, it is much smaller than the right lobe. There are instances of thyroid ectopias where there are migration defects, and this is just very early on during formation before even birth. Sorry. Okay, we're going to go into goiters, 5 questions that we're going to ask when we speak about goiters. We're going to be faced with, is it a goiter? Are there signs of compression? Is there a context of thyroid dysfunction? Is it a nodular goiter? Is it a painful goiter? Usually a goiter refers to a diffuse hypertrophy of the thyroid body. Usually in adolescents, it is greater than 16 cubic centimeters. In females, it is greater than 18, and in males, it is greater than 20. Usually a palpable thyroid is not, I'm sorry, there's 2 rules. A palpable thyroid is not necessarily a goiter, and a goiter is not necessarily palpable. If the gland has a normal volume, we will conclude that, of course, there is no goiter. If we're suspecting that there is a goiter present, we would try to confirm first with ultrasound because it is cost effective, it is non-invasive, and it is a simple procedure to diagnose the patient. If the volume is less than 20 cubic centimeters for males or less than 18 for females, we would say there is no goiter. If it is confirmed by ultrasound that there is a goiter, we would ask, are there signs of compression? And if so, we would have the patient sent for a CT or an MRI. This is an example of tracheal compression. So this would warrant further evaluation of the thyroid, such as an MRI. There are other anatomical structures that would be affected, let's say, if there is enlargement or inflammation, and that would be the nerves. With ultrasound, we do not really observe or look at the nerves. However, the doctors would probably be interested in that, and there would be further evaluation into how a goiter or the surrounding area is affecting other areas, such as compressing a vessel or a nerve. And you would evaluate, and it's always important to ask a lot of questions when evaluating the patient, because it will give you information on if this is affecting, let's say they're having a certain type of pain, you can probably associate that with nerve pain, and you'd be able to say that something is causing further pain due to compression. So we'll give you clues on the size of what's happening in the thyroid if there was something like a nodule that should not be there. There are times where thyroid dysfunction also plays a role, such as hyper or hypothyroidism. There are autoimmune pathologies also, such as thyroiditis. Also, we know that there is a variation of the size of the glands due to atrophy or hypertrophy. This is an example of hyperechogenicity of the septal fibrosis with the evolution of the affection, delimiting the hypoechoic lobules. Thyroiditis. The main characteristic of thyroiditis on ultrasound is hypoechogenicity. Lymphatic thyroiditis is also called Hashimoto's. This is a more chronic event. Subacute thyroiditis is decorvane. Acute thyroiditis is usually bacterial or viral. And then we also have fibrous thyroiditis. Autoimmune immune thyroiditis is usually associated with histological damage in the presence of circulating antibodies. In terms of Graves' disease, usually it's a constant goiter or enlargement between 20 and 60 cubic centimeters. It's typically present, in patients that have clinical signs. Usually the presence of an anti-TSH receptor or antibodies is also observed. On ultrasound, the thyroid gland appears hypoechoic, especially at the beginning with a honeycomb appearance. In the image shown, we can observe the same thyroid gland with the colored Doppler, and you can see that it is very hypervascular. So one of the signs of Graves' disease would be hypervascularity. And this is the honeycomb reticulations, as you can see here. Hashimoto's disease, we're going to go into that, which is a chronic autoimmune inflammation of the thyroid with lymphatic infiltration. Usually, clinically, it is non-painful. It's usually gives off hypothyroid symptoms, hypothyroid. Signs warranting an ultrasound is usually just cervical discomfort, pain, enlargement, or signs of hypothyroidism, which is usually seen on blood work and looking at the numbers on a patient's hormonal testing, such as the TSH. On a biological level, the TSH concentration would be measured and evaluated. Antibodies are also tested. Regarding treatment, it is up to the doctors to decide the treatment, but, generally, very commonly, replacement hormone therapy is, a very common method in terms of controlling the thyroid. A very popular thyroid medication would be levothyroxine, which is, once again, hormone replacement therapy. This is also another picture here in the case of Hashimoto's thyroiditis. It can resemble Graves' disease with the presence of small nodules and hypervascularization. In this particular image, you can see here the hypervascularization and the difference in the thyroid texture compared to what a normal thyroid would look like. It's very hypoechoic with very hyperechoic areas. This is another image of a Hashimoto's thyroid, which is a little bit on the smaller ends than, I would say, your normal thyroid. This is also another image of an abnormal thyroid with irregular echogenicity and hypervascularity. Okay, so now we can see that if we have signs of compression with the patient, usually they would be sent for a CT or MRI, thyroid dysfunction. We would check biologically a thyroid hormone panel, and then we would also the doctor would decide if the mass is a goiter or if it is painful, and then treatment would continue from there. Decorvent subacute thyroiditis. All right, so moving on, with this type of thyroiditis, It's a seasonal viral pathology. So symptoms can include pain, it can include fever. Usually we will see some hypoechoic areas with indistinct boundaries. The initial phase would be moderate hypertrophy, hypoechogenicity, and usually undistinct borders, and we would see some hypoechoic zones and poorly vascularized areas when utilizing the Doppler. In this image, we can see an example of subacute thyroiditis displaying a glandular hypertrophy of the hypoechoic or isoechoic regions with the healthy areas. It also demonstrates signs of inflammation. It is also very important to consider inflammation because the echogenicity will be normal because of edema. And also, you know, there's an influx of fluid. This is another image of subacute thyroiditis. Okay, and also here we see the same findings, hypoechoic and not very hypervascular. All right, now we can discuss hematoceles. A hematocele refers to a thyroid nodule that is not completely, I would say, solid. Usually it is a vessel that ruptures, leaving behind almost a pocket full of blood, almost like a thyroid nodule, but with blood formed inside of it, basically a hematoma. It will appear anechoic, it would lack echoes. However, it will look very thick, and it can have some very low laying echoes within. Right, so this is our chart in how to manage the goiters once again. This is a very simple an image of a goiter without any specific pathology. So this is just an enlarged thyroid, basically, with the echo texture remaining normal. We do not see any nodules or any discrete areas within the thyroid in the longitudinal or in the transverse section. Now we will go into nodule pathology. So of course, one of the most common things that we find in the thyroid are nodules. This is very key. It is very frequent, especially in adults 50 years or older. So it does, the frequency does increase with age, and it is usually more common in females, 3 to 1 compared to males. In this graph, we can see that the ultrasound, in fact, is more likely to be found as the, I'm sorry. It can, okay, it is most likely to be detected on palpation, correct. All right, so usually to categorize a thyroid, we use a TIRAD system. This system usually will describe the nodules in terms of size, vascularity, microcalcifications, and categorize it on kind of like how what the risk is in terms of malignancy. So it would give it a score and help us distinguish, is the nodule more benign versus more malignant. Okay, so in terms of description of a nodule, it is very important to be very specific because these factors play a key role in determining is the nodule leaning more towards benign or more towards malignant. And it will also help the doctor decide the next step. So localization is very important to note in your thyroid report if you're finding a nodule. The size is very important. So you're going to measure length, width, and height. You're going to make note of the shape. Is the thyroid more ovoid? Is the nodule more ovoid, more round? Are the borders? Borders are very important. Are the borders more discrete? Are the borders irregular? The echo structure, is the nodule more hyperechoic, more hypoechoic? Is it mixed? The echogenicity, are there calcifications within, which is very important? And is the nodule vascular? Is it filling up with a little bit of color? Does it have a vascular stalk? You can be very specific with the vascularization as well in terms of noting where it's filling up with color. It does make a difference sometimes in determining what type of nodule and the grading by making note if as if the vascularization is more going around the area, going within the area, is the vascularization throughout the nodule. So you can be very specific about that as well, and it would really help the doctor. All right, so when we are numbering the nodules, each nodule is given its own number, and as the patient is coming in or going to, if they came to one imaging facility and went to another, we have to keep that number the same for each nodule to ensure that the nodules are accurately being described and it is the same nodule. The number never changes and the same number represents each nodule. So as I mentioned before, when nodules are present, it's helpful sometimes to create a diagram. At my last office, we did diagrams all the time, and it would help us locate the nodules and communicate more effectively between myself and the doctors. So you can see here, in some offices, we would have, mixed echoes like this. We would have anechoic nodules we would fill in, and sometimes we'd leave them a little bit more uncolored if they were solid. So this also depends on the office where you are working and the preference of the doctor. So for thyroids, we do have the grading system 2, 3, 4, and 5. Of course, 2 is benign with very low risk. It indicates usually that it is a benign nodule with an extremely low risk. 1 would just be there's no nodules. 3 would be a very low risk of malignancy, I would say from 2 to 4%. 4 would be intermediate risk from 6 to 18%. And 5 would be elevated risk from 26 to 87%. Right, so a level 5, we'll start from here, from the top, would be a sign of high suspicion. Usually the shape would be a non-oval shape. It would be more thick, or it would be more thick than long, or it would have irregular contours. The microcalcifications would also be present. So with even one of these signs, the risk does go up to about 26 to 85%. Okay, and this is another, this slide is showing grade 4, grade 3, and grade 2. So grade 4 would be moderately hypoechoic, partially hypo, solid, or mixed. About 27% of nodules fall into this category. 20 to 40% are carcinomas. The risk is about 6 to 17%. 3 would be isoechoic, hyperechoic. A weaker risk, about 63% of nodules fall into this category. Less than 5% are carcinomas. The risk is not very high at all. It's 2 to 4%. For thyroids 2, about 5% of the nodules fall into this category, and 0 are usually carcinomas. All right, in this slide, we have a few different images. So this image is showing a non-oval shape. So we can see that the shape is irregular in this image. And these images would be fall into a score of 5. There's also an image showing microcalcifications. Microcalcifications are solid structures that typically produce an acoustic shadowing. We have irregular contours in this image, and in this image we can see that the nodule is hypoechoic compared to the rest of the thyroid. This is another sign of elevated risk. It would be irregular contours or borders. So this is a nodule here, and the borders are irregular. We also have some microcalcifications here with some acoustic, without the acoustic shadowing. This is also images that would show a level 5 thyroid risk level. This is an image here with indistinct borders as well. And then we have an image here of a hypoechoic nodule, and this is the thyroid there to compare the echogenicity. For a score 4, which would represent an intermediate risk, it is important to know that it is defined by partial hypoechogenicity, oval shape, and the nodule can have regular contours. Okay, this is an example of the thyroid 3 low risk image. We see an oval shape and regular contours. We can see here the lobe can be considered a low risk thyroid 3. We can see some isoechoic nodular clusters. Finally, we reach a score 2, which comprises of 2 types of nodules. We have a simple cyst and we have a spongiform nodule, which is called a spongiform because it resembles a sponge. The simple cyst is here, just completely hypoechoic, filled with fluid. So the signs that we are going to primarily look out for is shape, contours, and echogenicity, along with those microcalcifications. Accessory signs, secondary signs would be echostructure, looking for a halo, which is a hyperechoic ring around the nodule, colloid granulations, vascularization, and extrathyroidal involvement. Let's see. Accessory signs that increase the risk. So as I mentioned, the halo here is a hyperechoic ring around the nodule. In this image, we can see an accessory sign would be oblique orientation. So this nodule is more in an oblique position. In this image here, we can see that there is extra capsular involvement. So the nodule is kind of pushing out of the border of the nodule, which you can see here. In this image, we can see a thin and complete halo around the thyroid nodule. This is a sign that decreases the risk of thyroid cancer or any further issues. I'm sorry, here we can also see a cystic component within the thyroid nodule. In this image, we are looking at colloid granulations. This also is a decreased risk with some cystic septations and a flattened shape. So this nodule is more flat than tall, and that is also a better sign. So we are moving on. Normally, if a thyroid nodule is less than a centimeter, it does not warrant cytopunction, which is also can be called a fine needle aspiration and FNA. So there's a few different terms for it. However, in general, if the nodule is less than a centimeter or 10 millimeters, it is usually not pretty much poked with a needle to get a sample for further evaluation. So some key points that we're going to take away from this is that there is a high prevalence of thyroid nodules that is found in patients, usually more so with age. 95% of them are usually benign. There are different types of thyroid nodules. There are different types of thyroid issues with hormone imbalances that can affect the thyroid, and it's very important to know how to use information from blood work such as TSH levels or even calcium levels, which would indicate parathyroid adenomas, in conjunction with ultrasound to determine a diagnosis. All right, so we're always going to look for cervical adenopathies also, which is abnormal findings or pathologies in the neck area surrounding the thyroid. I mean, we're already evaluating the thyroid. I think it's very important as a sonographer to look at the surrounding areas as well. So the advantages of using the ultrasound to explore the cervical region as well. It's no radiation, there's no pain, it is not invasive, and we can also use this scan with the thyroid to compare previous and future exams. It also helps with communication between colleagues and patients. It's important to note that if I'm scanning a thyroid and I notice an enlarged lymph node, the next person that is scanning that patient, maybe in 6 months to a year, they can compare that lymph node and continue the patient's care. So we will now discuss the salivary glands. The salivary gland, starting with the role, the significance in ultrasound, and the exploration. We will also be going into the lymph nodes right after. Why is the imaging of the salivary glands important? Well, it would help, confirm different issues. It plays a role in determining issues in the neck along with the thyroid. We will use conventional tools such as ultrasound if the doctor would like, if there's something that warrants, they would do further exploration with CT or CAT scan. Right. Usually the benefits, like we said, for the ultrasound in exploring the salivary glands and surrounding areas would be that there is no pain. It can be compared, and it's great to use this information in the patient's throughout the patient's medical history. It's also economic because ultrasound is very inexpensive usually. With the anatomical reminders, there are 3 major salivary glands that are present bilaterally. The 3 main glands of interest are the parotid and the submandibular glands. Okay, this is a beautiful visual representation of the parotid gland, which you can see here, the submandibular gland and the sublingual gland. This is another view showing the parotid, the submandibular, and the sublingual. The parotid gland is the largest salivary gland. It has a prism-like shape with a wide lateral base, 3 edges, and 3 faces. The Stennin canal is 1 to 2 millimeters in diameter, and the length is usually 0.4 centimeter, and it emerges at the anterior edge of the glands. From the posterior view, we can observe that the parotid gland it primarily encompasses the angle of the jaw. So you can see here. I'm going to go to the next one. So this is another image here. So in this image, we can also visualize the sternocleidomastoid muscle, the parotid gland, and the masseter. This is another image here of all of the structures and how they relate to one another in terms of anatomy. Okay, parotid location. So the limits, it is in front, the ascending branch of the mandible. Outside, there's skin, adipose muscle, and subcutaneous tissue. From behind, we can also view, but you have to be very particular with your angles. This is another view of the facial nerve, the parotid, and the Stennin canal. This is another image of parotid location in terms of where it is located with the external carotid arteries. The submandibular glands, they do have a triangular shape with a posterior base. They're bordered externally by the mandible and internally by the suprahyoid muscle. In this image, we can visualize the Wharton canal and the submandibular gland. The sublingual glands are located in the floor of the mouth. They're elongated, transversely flattened. In terms of size, they're in length, it's usually 3 centimeters with 6 to 7 millimeters and height 15 millimeters. This is the frontal view, which is presented here, and it shows the location of these sublingual glands beneath the jaw. Now we're going to explore more the exploration technique of the salivary gland. We would use a linear probe, high frequency. We would use real-time mode, which is B mode, and color Doppler, which is also very important to look for vascularization and hypervascularity. The patient's head would usually return to either side and up and down, depending on which area is needed to be visualized. In this section, we are examining the parotid gland of the patient. We explore the organ using longitudinal and transverse sections. We are scanning up and down, and we will scan left and right. We are scanning the submandibular gland here as well, and we want to make sure that we explore always the entire gland. We are scanning up and down, and we are scanning left to right always. What are the normal findings of the salivary glands? So they usually have regular contours, and the echo texture is usually homogeneous. It does have a thyroid type echogenicity, as I have observed in many patients in general. And sometimes you can have the presence of a parathyroid intraparenchymal node. Excretory ducts are rarely visible if not dilated. Okay, so we are going into the images now of the parotid glands. Here's another image of the parotid glands. And this is another image. And as you can see, it does have a similar echo texture to the thyroid. This is the submandibular gland, as you can see right here. This is another image of the submandibular gland. These are the borders. What types of pathologies can be encountered? These pathologies are mostly found in the parotid and submandibular glands. So one of the most common would be cyelanditis, parotid adenitis, cyalolithiasis, megachannels, and tumors, which can be classified as malignant, benign, malignant, cysts, or pseudocysts. Commonly with cyeladenitis, we see an increase in volume, homogeneous echo structure, increased vascularity, ductal dilation. And we would also check the surrounding cervical area for any type of enlargements or abnormalities. If it is a bacterial or fungal type of involvement, there would also be an increased volume and a heterogeneous echo structure with dilation as well. This is responsible for salivary colic pain. 70% affects the submandibulars, 30% the carotids. Also, again, the signs for ultrasound would be increased volume, ductal dilation, intraductal lithiasis, and a few other symptoms. This is an example of parotid ductal dilation in this image, and we can also see that there is some acoustic shadowing. We can see in another image, very similar. This is the ductal dilation here. Megaducts or megachannels refer to ductal dysplasia. It's secondary to a stricture of the sphincter or to a stenosis. And it's usually responsible for salivary hernia. Parotid adenitis, it's usually seen with hypoechoic lesions. It's limited and it's centered by a hypoechoic zone or a hilum. Here's a picture of parotid adenitis. We can see it's showing an ovoid formation within the parenchyma, and it does have clear boundaries. Cysts are anechoic formations with posterior reinforcement. Internal partitions may sometimes be observed. 80% of these the tumors affect the parotid glands, more frequently benign than malignant. An ultrasound allows for their localization. If there's further observation needed or further imaging, an MRI would be considered. Going into benign parotid tumors, pleomorphic adenoma is the most frequent benign tumor. It's usually solitary. It's usually a solitary lesion, painless, very hypoechoic, homogeneous, bumpy but regular contours with posterior reinforcement and moderate vascularization. Pleomorphic adenoma. This is another image depicting this. It highlights its characteristics of bumpy edges and hypoechoic appearance. And then we have another, this is an image here of a cyst adenolipoma depicted in this image, demonstrating areas of vascularized tissue and cystic regions. Malignant tumors are the third leading cause of parathyroid tumors. They exhibit heterogeneous structures with poorly defined boundaries. This is an image here. The image of the malignant tumor here shows jagged contours, increased vascularity, and hypoechoic areas. Other tumors include hemangiomas, which is the most common salivary tumor in children, monomorphic adenomas, schwannomas, and parotid lymphomas. Now let's discuss the ultrasound and the study of the lymph nodes. The lymph nodes are very important because we can determine if there are things like an infection or inflammation going on in the thyroid or in the body, usually in general. Okay, the ultrasound of lymph nodes. So what is the role of ultrasounds while scanning the lymph nodes, the different sections? We will also speak about how to scan the lymph nodes, normal ultrasound findings, and pathologies. Okay, so ultrasound is usually the first line exam, once again, because it is economical and it's very non-invasive. It aids in the diagnostic process along with the clinical examination. These are the anatomical sectors. They are divided in the following regions. First, the lateral zones, which are limited medially by the carotid arteries, superiorly by the submandibular glands, and inferiorly by the clavicle. These are the different regions here. We have sections 1, we have sections 2, 2A and B. We have sections 3, 4, 5, A and B, and 6. So it's very important to know where you're finding an abnormal lymph node or where there is some type of suspicion. Okay, this is an image depicting where the hyoid bone lays in terms of the thyroid lymph regions. These are the lateral zone borders. We have the submandibular glands, and we have the primitive carotid. These are also the borders of the lymph nodes. You can study this. I do recommend studying this chart on your own in depth. And I usually have a chart with me when I am scanning the thyroid to make sure that I'm correctly locating everything and marking it correctly. These are the anatomical sectors. So just to kind of summarize the anatomical regions, we have sector 6 and 7 in front of the trachea, sector 1 submentally, and the thyroid gland located in sector 6. Regarding the patient's positioning for scanning the lymph nodes, it's pretty much the same as scanning the thyroid. And I would just also always, as usual, make sure that your patient is just very, very comfortable. We're going to go into the probes. Usually we're using a high frequency probe as well, ranging about from 7.5 megahertz up to 10 if we were wanting to see more in terms of microcalcifications. Again, the modes, we are using the same B mode color Doppler, and we're also using power Doppler. Different sections would be the same, bilateral, longitudinal, and cross sections. To determine what constitutes a normal lymph node versus a abnormal lymph node, we will focus on things like the hilum, which is the inside area of the lymph node, the shape, the size, and vascularization. So almost the same as a thyroid nodule. Okay, the hilum of the lymph node is visible in about up to almost half the cases. Only its presence has an important value, and usually we only see it with colored Doppler. Here in these images, they are displaying different shapes of the hilum. So this is the lymph node here, this is the lymph node here, and this is the hilum, which is the bright area in the middle. This is another lymph node here. It is not as hypoechoic, but you can still see the hilum here, and they do have the color turned on to see the vascularization around the area. Okay, this is another image of a hilum variant. So this is a ball-shaped, this is, I'm sorry, the lymph node with a ball-shaped hilum. It's more round. This hilum in here is occupying almost the whole lymph node. So this is the lymph node. This hyperechoic region in here is called the hilum. Here it is more round. So you're going to want to pay attention to that, and it's very important to have the gains on your machine set so that you can see any difference between hypo and hyperechoic in your structure. So the gain settings is very, very important in looking for nodules and observing the lymph nodes itself. Normally the lymph nodes are flattened and oval. They can be round even when they are normal in about 36% of cases, even if they're small. We do measure the thickness, usually about less than or equal to 10 millimeters in sector 1, equal to or less than 5 in sections 3 to 5. The hilums, we usually see them in 50% of, more than 50% of lymph nodes. It's absent in about 30 to 30% of normal nodes. So this indicates that the hilum is not the only thing that we would look for in terms of an abnormal lymph node. This is an image here, just showing the power Doppler and showing the vascularization. So this is just regular color Doppler, and this is power Doppler. So it does make a huge difference sometimes with observing the vascularity within a lymph node, and sometimes I've seen this difference within thyroid nodules as well. So I would say power Doppler is a great tool in observing lymph nodes and observing the thyroid itself. Okay, now we're going to discuss reactional adenopathies, the clinical content, the lymph node volume, when is it suspicious, ultrasound aspect of a normal node, possible pain, and having multiple suspicious nodules. So these suspicious nodes usually are painful when examined. They can form cystic formation, and usually the hilum is not seen. So usually there's no visible hilum. So the hyperechoic region in the middle is usually not seen. There are cystic formations. So these are lymph nodes with cystic formations within. So this is the lymph node, solid area, hilum area. This is the cystic area, which is the anechoic areas there, which is hypoechoic to the hilum, as you can see there. In the case of a tumor invasion, we would see we would see signs such as microcalcifications. Also, we would grade. So the grading system is grade 1, grade 2, and grade 3. The normal, well, this is vascularization of the lymph node. It's shown using a power Doppler. And as you can see, we have color filling around and within. This is abnormal echogenicity of a lymph node. It closely resembles a thyroid lobe, and this indicates malignancy. Normal, another sign of abnormal echogenicity. You can see that the hilum is not clearly seen and the lobe is actually taller than wide, which is not a good sign. Also here, you can see many cystic regions within the lymph node. It is no longer a simple ovoid structure with an echogenic middle interior region. This is another example of abnormal echogenicity. We're seeing structures of cystic pockets and solid. Usually further investigating would be done with these. This is another image with abnormal echogenicity of the lymph node. Okay, so this is the chart that we would use to determine if the lymph node is more normal or suspicious, very similar to the classification of thyroid nodules. I would print this out and keep this with you if you are scanning thyroid and lymph nodes to just, be able to know what to look for and what is suspicious and what is not. So this is a great chart to have, and it talks about the presence of a hilum, visible or non-visible, the shape, the echogenicity, and the vascularization. You can see with each one, it changes. So normal would be a high lymph seen. Suspicious would be no high lymph seen or an abnormal. And that would be intermediate, I'm sorry. And very suspicious would be no visible hilum. And in each of these categories, you can see how the appearance would affect how something would be more suspicious or not. Some students or some texts find it helpful to draw. You can also draw where you are seeing your lymph nodes, and you can use color. So also the regions would let you know if the lymph node being enlarged or suspicious would have a greater chance of being malignant or benign based on location. So this would be a suspicious area, doubtful area. This would be a benign, more of a benign area closer to the clavicle. If you found an abnormal lymph node, you'd be able to differentiate the significance using that graph. The differential diagnosis, sometimes lipomas are found right under the skin. They're mobile and they can be mistaken for a lymph node. A lymphocele, which is a fluid-filled structure, it can develop during lymph node dissection surgeries, trauma. A schwannoma is very painful. It can be an epidermal cyst. So there are other things that would stand out that would help you differentiate if this is a lymph node or something else, or further imaging would take place. But always use your color Doppler and all of your tools that you are able to use. Okay, this is a differential diagnosis showing the lipoma and how similar it is. It's elongated, it's well limited. We can see the borders really nicely. It's soft, mobile, it's right under the skin. So very similar to what a lymph node would feel like upon palpation. This is a lymphocele. So lymphocele is mostly filled with fluid, so it will be more anechoic. This is a lymphocele puncturing with a needle, so they are taking a sample from that in this image. A cyst is also round, well limited, avascular, and heterogeneous. A schwannoma is usually hypoechoic and well limited. The lipoma seen here is hypoechoic, sometimes heterogeneous, anarchic vascularization. It is important to clearly describe the lymph nodes, the shape, the vascularization, the presence of a hilum, the location, and to determine if the lymph nodes would be more malignant or benign.